How is it that we find ourselves surrounded by such complexity, such elegance?
The genes of you and me, the genes of you and me, we're all made of DNA. We're all made of the same chemical DNA. We're all made of DNA.
Hi, you're watching DNA Today, a multi-award-winning genetics podcast where we explore everything to do with genetics, from CRISPR to rare diseases to new research. We have won the Science and Medicine Podcast Award for many years now. We have hundreds of episodes, and we really hope you enjoy these conversations where we dive into so many genetic concepts. I'm Kira Deneen, a certified genetic counselor, and your host.
Hello, DNA Today listeners. I'm Jessica Fernandes.
And I'm Yalda Safaei, and we are rising second-year students in the Genetic Counseling Graduate Program at Sarah Lawrence College. And today we're thrilled to be hosting the DNA Today's episode as part of our summer rotation.
Yes, so our guest today is Dr. Lisa Diller. Dr. Diller is the Vice Chair of the Department of Pediatric Oncology and the Director of the Perini Family Survivors Center and the David B. Perini Jr. Quality of Life Clinic at the Dana-Farber Cancer Institute in Boston. Additionally, she is the co-director of the Pediatric Cancer Genetic Risk Program at the Dana-Farber Boston Children's Cancer and Blood Disorders Center. Dr. Diller's research focuses on the late effects of treatment for childhood cancer and genetic cancer predisposition syndromes in childhood. Welcome, Dr. Diller.
Hello, nice to meet you both.
So, Dr. Diller, what initially sparked your interest in cancer predisposition syndromes in children?
Well, that's such an interesting question with a very long answer. I've been a pediatric oncologist for over 30 years, and while I wasn't training, I remember seeing a couple of patients who had more than one cancer. Children who had had a cancer as a very, very young child, and then 10 years later developed another cancer, and then 3 years later another cancer. And there I was as a new oncologist walking in, and this child had already had 3 cancers. And I thought, what's this about? And right about the same time, the RB1 gene had been identified, which is a gene associated with a kind of classic cancer predisposition syndrome called bilateral retinoblastoma. And people have been making family trees, studying pedigrees of kids with bilateral retinoblastoma for many years. And the 2-hit hypothesis, which we can talk about later, had been kind of proposed. And then right about when I was doing my training, a member actually of our group who had been a fellow before me, Stephen Frenz, cloned the RB1 gene. And I thought, well, genes like that are going to explain all of childhood cancer. That's kind of what I want to do, is I want to find the other genes, just like RB1, that are associated with childhood cancer. And so I went to the lab, and that wasn't the project I got. I cloned the RB1 gene in xenophus, which are frogs. And I hated being in the lab, but I still was compelled to think about cancer predisposition and its implications for public health. And it turned out that Fred Lee, as in Lee-Framini syndrome, which we can also talk about later if you like, Fred Lee was an epidemiologist who had described a high risk of cancer in kind of like dyads, in families where there were young women with breast cancer and their children had early onset sarcomas. It was called breast sarcoma syndrome before it was called Lee-Framini syndrome. And people were working on that gene, which turned out to be P53. And so I left the lab and worked with Dr. Lee to work on cancer predisposition and P53 and RP. And then shortly thereafter, WT1 was discovered. So I kind of started my career at this very beginning stage of understanding what the genes were that might be associated with childhood cancer. That's a long answer to the question. An even longer answer is when RB1 was first identified, I was 100% sure that like next week, there would be newborn screening for RB1 or for the retinoblastoma protein, like for finding newborns who were at risk for retinoblastoma. This is over 30 years ago. And I went around to like meet with various scientists to ask them like, well, is there a functional assay? Because they couldn't really think about doing gene first newborn screening back then, but there was a lot of biochemical stuff going on. I was like, well, there must be some functional assay we could come up with that'll detect, either like a low RB1 protein level or abnormal proteins or poorly functional proteins. And everybody just kept saying, everyone I talked to, all these scientists kept saying, wait for genetics. We'll do it genetically. So here we are over 30 years later, and I'm still convinced that RB1 should be or testing for hereditary retinoblastoma risk should be a test that's incorporated into newborn screening, and that's what I'm working on.
Yeah, thank you so much. So I know that you kind of touched upon it in your answer, but maybe if you could explain for our listeners, what exactly is a cancer predisposition syndrome? Like, what does it mean to have a predisposition for cancer?
I think people are most probably familiar with breast cancer predisposition syndromes, that there are families with women, sisters, a mother and a daughter, or many female relatives, occasionally a male relative who has developed breast cancer, and that there's a gene that runs in that family. And I think many people are aware of those genes. They're called the BRCA genes. People talk about, did you carry the gene? Do you not carry the gene? And that puts you at increased risk for breast cancer. Breast cancer is pretty common in the general community anyway. So a woman can develop breast cancer and either have the gene or not have the gene. That's kind of what people talk about. And what they mean by that is like everything has the gene, but what they mean is that they have a copy of the gene that's not working well. Cancer in children is really, really, really rare. There's a sense that some children who develop cancer develop it for kind of the same reason. There's a gene that's not functioning well that we either have identified in some cancer predisposition syndromes or we hypothesize to exist in ones we don't know the gene associated with it yet. That increases the risk of developing a childhood cancer. And that increased risk can be a very, very increased relative risk relative to the general population. The chance of a child getting that cancer can be quite high. And the risk can still be like a little bit on the low side because childhood cancer is so very, very rare. I didn't really answer your question. The cancer predisposition syndrome is a syndrome in which a person is more likely to develop cancer than you would expect in the general community because they carry a gene that is altered in some way. Usually, but by carry, I mean it's a change in every cell of their body, and the cancer develops because every cell of their body is kind of not as good at keeping cancer from growing than if they didn't have that gene.
Dr. Diller, so you've been talking about newborn screening, and just for our listeners, I wanted to kind of define what newborn screening is. And it is a public health program that tests infants for serious but rare health conditions shortly after birth. And these conditions are often treatable, but they may not be clinically evident in the newborn period. And so, these conditions can be cancer or they can be, a variety of things. But I'm wondering if you can provide an overview of the current state of newborn screening for cancer predisposition specifically. If there is anything happening currently, whether in New York or other states, what your knowledge is.
There's no cancer predisposition screening in newborns as a public health intervention in the United States that I know of. Sometimes people call this the heel stick. When a baby's born, the baby's taken away by the nurse and they do a little heel stick, and they're testing for a variety of illnesses, some of which are kind of like required by the state or by the government as a public health measure. And others of which are kind of considered supplementary, and those vary state by state. I don't think any state is currently doing RB1 or any other, which is the one associated with bilateral retinoblastoma risk, or any other cancer predisposition gene. There's a state in Brazil where there's a very high allele frequency of, from a founder effect, meaning like somebody moved from Portugal to Brazil to this one state in Brazil, and that person carried a mutation in the TP53 gene, a specific site that's associated with an early onset of adrenal cortical carcinoma. And in that particular state, they do newborn screening for that specific mutation. So that's one example of where a gene, newborn screening for a genetic diagnosis for cancer risk is being done in a very limited setting. And then all over the world right now, there are pilot studies of whole genome and whole exome and targeted panel sequencing, more not about cancer per se, but more about understanding how we're going to do, or if we should do, what people call gene first diagnostics or gene first screening in newborns. And some of those panels include cancer predisposition genes like RB1. There was a paper published from a group in China recently where RB1 was on the panel. And I know this because when they reported the outcome of their testing, something like 30,000, I don't remember exactly how many people, but something like 30,000 babies, they found one carrier of an RB1 gene, and then they note that that patient was screened and diagnosed with retinoblastoma. So it's like the first example I can find of like, it worked. So, yeah.
And I know you talked a little bit about this just now, but can you talk a bit about the ongoing research surrounding newborn screening for cancer predisposition?
Sure. Let's say that newborn screening for cancer predisposition is a niche area. There aren't a lot of people working on it from the point of view of cancer predisposition. As I said, there's a lot of people working on gene first newborn screening, which will include cancer genes. But not a lot of people, meaning oncologists or newborn screeners, have teamed up to think about the intersection between oncology and newborn screening. My colleague Jennifer Ye, who's an expert in modeling, so sort of like predicting using decision science and modeling, theoretic. I'm going to start that one again. My colleague Jennifer Ye, who is a modeler, meaning that she can take a medical idea or an intervention that we can't actually do in real life and model it. What would happen if we did that? So one of the things we can't do in real life, for example, is take a population of newborn babies in the United States for a year and screen them all for cancer predisposition genes. And then the following year, not screen anybody, that show or randomize people to one or the other, and then show that newborn screening made a difference or not. It's just not possible to do for a variety of reasons, but you can model it. So Jennifer and I modeled what would happen if you introduced gene first newborn screening for 11 selected genes that were selected by me essentially because I know that they're associated with very, very early onset solid tumors and brain tumors. We chose those based upon the principles of newborn screening. So we chose very early onset because in general, newborn screening is supposed to be done at the time of birth because you want to make a difference in the first few years of life. If something's not going to happen to the person's age 30, they have many, many years to decide whether they want that test or not. But for the diseases that occur in the first few years of life, the newborn period is a good place to do that testing. So we chose that criteria. And then the other criterion that we chose was brain tumors and solid tumors because those are tumors for which there are very good surveillance recommendations and an inkling that if you find those tumors early, you might improve outcome. And by improving outcome, we higher rate of cure, but we also mean less likely to need significant chemotherapy or radiation therapy, or less likely to be left impaired by the tumor or the therapy itself. So that was the model that we built and published, which showed an impact, a hypothetical impact on survival that overall in the United States, if we incorporated those 11 genes into newborn screening, we would reduce mortality from childhood cancer by about 8%. And because of the way we built the model, it's not real, we didn't really measure it, in the kids who were carriers, we would reduce mortality by about 50%. The cost effectiveness was not great, but it's totally based upon the cost of the sequencing, because everybody gets sequenced. So it's not based upon the cost of surveillance or the cost of genetic counseling or any other factors, because those are so small against the cost of sequencing the entire population. So as the cost of sequencing goes down, I think the cost effect.
That's great to hear that, there's some people at least looking into this, and modeling is definitely a very interesting way to go about, circumventing some of these research blocks or ethical considerations. So I'm wondering, what would you consider that, or are there other more significant challenges to implementing widespread newborn screening or for cancer predisposition, or are those kind of the main ones?
Well, when you asked about who else is kind of working on it or what work is being done, I think it's important to point out that across many newborn screening experiments that are going on that are gene first, there are cancer predisposition genes included in some of those studies. So we will get data from that. A really important piece of missing data, and probably the hardest thing that we're going to have to do, is to figure out what variants to report on. So if you take a whole population and you figure out some cost-effective way to do targeted sequencing of X number of genes, and then you have an AI-assisted system to report on variants, you end up with a pile of variants, some of which are, going to be known pathogenic variants associated with the tumors. But some are going to be kind of like likely pathogenic, variants of unknown significance, that are associated with possible loss of function, things we don't know. And these are healthy babies. We're not testing kids with cancer now. We're testing healthy babies. So I think one of the hardest things we're going to have to do is figure out what to do with those. One of the things that would help the most with that is doing this on a lot of healthy babies who we know didn't develop cancer, like getting large numbers of what we call, healthy controls. Now, you could use population-based data like from data sets like NOMAD, where you can look and see whether or not that variant's been described in normal populations. Those are usually not children, so you've already kind of weeded out carrier children, in a sense, who didn't survive their disease. There are also adults who might participate in studies like that who either don't report or don't know that they had a childhood cancer. They had a retinoblastoma, and, all they know is they had something wrong with their eyes when they were born and the doctors treated it. Or they have, I've met people at age 50 who just found out they had a Wilms tumor, which is a childhood renal tumor. And they didn't know. They just knew that, their parents told them they had a kidney out when they were a kid, that they have no memory of it. So the population-based data from adults is a little fraught, probably mostly by the fact that the data is skewed to get rid of or to not include variants that might be really important in predicting disease, because those people don't survive into adulthood. And then some, people who survive into adulthood who can't be excluded in a non-cancer normal population because they consider themselves non-cancer, but they actually are cancer survivors. Does that make sense?
Mm-hmm.
Yeah, so the answer to your question is more data. And the impediment is we need funding to be able to do the sequencing on large numbers of patients. So we've applied for a couple of grants and we'll continue to do so. The cost of sequencing when you're talking about large numbers is also kind of problematic and so we're working on technology which pools samples. During COVID, a lot of large labs started pooling samples so that if you do a pool of 10 samples was negative, you didn't have to go individually and separate those out. You do that, all of those 10 people were COVID negative. And that raised the question, could you pool other kinds of samples when you're looking at rare diseases? And so one of the things we're working on now in newborn screening and cancer risk genes is sample pooling, so that if an entire pool is negative for a deleterious variant, then you can assume every individual in that pool is negative and move on to the next pool, and that will save them.
And what are some ethical considerations that arise when considering this like population-based screening for cancer predisposition?
It's a great question to think about the ethical implications, because there are many. One major issue, I think, is what in genetics, challenge genetic counseling, I'm sure we call incomplete penetrance. In other words, we can give a parent information about a genetic change found in their baby, but we can't predict, in the setting of most of the genes that we think about, the penetrance. So we can't predict whether or not the child will get cancer and at what age the child will get cancer. So why is that an ethical consideration? Because you've taken a well child, is perfectly well, and in the parent's eyes, kind of given them a label as at risk. Well, in fact, they may never develop cancer. So there's an ethical issue there, I think, on the backs of people like myself and genetic counselors and newborn screeners, to make sure that this is something a population of parents would be comfortable with, at least theoretically. Couple of ways we're doing that is qualitative interviews with parents of kids who do have cancer predisposition syndromes, who having their kids go through surveillance and how that feels. Kids who haven't developed cancer but have been identified in the course of a workup for seizures or because of a family history or some other reason that a baby is identified as carrying a variant in a gene that puts the child at risk for cancer. And now they're undergoing surveillance, let's say ultrasounds or something every few months. So we've been doing interview studies with those parents to understand exactly that. Do they see their child at risk? Should they treat that child differently? Do they wish they'd never known? Is the surveillance anxiety provoking, or is it reassuring? Because that would provide a model somewhat for the parents who we would pick up, or the babies we would pick up in the setting of newborn screening. Another way I think we have to think about the ethics is gene by gene. Personally, I think it's sort of like a failure of modern medicine or genetics to not have RB1 screening and newborn screening, because there the penetrance is 90-95%. So that's an easy one. But, what about one where the relative risk is 1,000, but the absolute risk is 5%? So sort of thinking of the ethics by each individual gene, because each one has different implications. The other ethical problem, I think, is around, as you know, as genetic counselors, once you find out something about an individual, about their genetics, it has possible implications for their parents and their siblings. So you're doing something to one person, and parent, might end up being a carrier themselves. So if we do newborn screening, let's say, for the TP53 gene, which is associated with the Perini syndrome, if we identify a baby with a TP53 gene, and as a pediatric oncologist and a person interested in this field, let's say I think that's ethical, and I thought that was a good idea. We could discuss that, but let's just say. But it means that there's a parent, or possibly a parent, could be it's a de novo mutation, but let's say it's inherited, who now really becomes a person at risk for cancer without their, we would recommend them getting genetic testing, and that they would find out that they're at risk for cancer. Now, you may think, or a person may think, well, that's wonderful. We've done something for that parent, improve their health and the outcome of their genetic condition, if you will. But you also might say that in newborn screening, we have kind of no business in dealing with the health of the parents. It's about the health of the child. We're sort of wading into issues of autonomy, for example.
So just kind of continuing off of that question, like what would the potential next steps be if a newborn is found to have, such a genetic marker indicating that cancer risk for, something, as you said, maybe the penetrance is not complete, so you don't know whether they will actually develop that cancer or not, versus something like Lee-Fraumeni, as you mentioned, where we know, especially in women, that cancer risk is nearing 100%.
Let's come back to Lee-Fraumeni. Remind me, when a baby, in my imagination, if we had newborn screening for, let's say, the RD1 gene, and it was kind of high throughput, every baby, just like we do newborn screening for all the other biochemical changes that we look at now. And so the pediatrician would get a report that probably a phone call from the state lab that there was an RD1 variant of concern, and would give the for the pediatrician information about the pediatric oncology and ophthalmology services that have been associated with this RD1 program in the state. That's what I imagine. That, for example, at my institution, we have a clinic for children who are at risk for cancer. We would see that child almost immediately. We would have a genetic counselor see the family. We would do clinic level, confirmation of the variant that had been seen in newborn screening. And we would have an intermediate eye exam of the child to make sure there wasn't evidence for retinoblastoma. I think that could happen for RD1. That could happen within a week or two of birth and would be fantastic. I'm going to tell you a story. I follow a family in our cancer risk clinic. This brings up many of the issues. Mom had an eye removed when she was a baby. She had no idea why. She never really shared that with anyone when she was pregnant. She had her first child. He was born and was fine. And at age 1.5 or so, was noted to have some funky things with his vision, and ended up having bilateral retinoblastoma, carried a mutation in the RD1 gene, and had a really hard time getting treated. Got chemotherapy, had to have surgery, had to have radiation, had to have surgery again, and is blind, completely blind. The mother's a carrier of the same mutation. She gets pregnant again, has a baby. Baby is born. They found to be a carrier, but even before they get the genetic results back, she has an exam under anesthesia in the first couple of weeks of life. They find tiny, tiny little tumors. They treat them with laser therapy. She gets exams under anesthesia, and then as she gets older, exams, without anesthesia, to pick up tiny, tiny little tumors as they grow over the first couple of years of life. Never needs radiation, never needs surgery, never needs chemotherapy, and has perfect vision. So that's the argument, if you will. She's the argument for why we should be doing this. I mean, in this particular case, it was a founder effect. The mother had it. She didn't know she had it because the brother had it. He was the proband. So the little sister was intensely studied, if you will. That kind of normal newborns wouldn't be studied, but that's what we're hoping for in with RD1. Getting back to Lee-Fraumeni syndrome, it's funny you mentioned breast cancer. I am not a big advocate of. I'm in fact a anti-advocate, whatever that's called. I'm opposed to testing for breast cancer genes BRCA1 and BRCA2 in children. I think that women have the right to make that decision for themselves when they reach an age of majority age at rest. Lee-Fraumeni syndrome is a funny one, though, right? Because BRCA mutations really, you can argue it a little bit, but they're not associated with at least a very high relative risk for childhood cancer. But Lee-Fraumeni, TP53 mutations are associated with breast cancer. You're absolutely right. they're also associated with very, very early onset cancers in children, like choroid plexus carcinomas and adrenal cortical carcinomas being the early ones that we see. So there's an argument for doing TP53 or including TP53 on a cancer predisposition panel in children. And the overall penetrance in childhood is probably only about 20% or so. So in the first 15 to 18 years of life. But we follow a lot of LFS kids in our clinic, and they get whole body MRIs, and other forms of surveillance to pick up tumors early, and those have been shown to be effective. So knowing that surveillance is effective in preventing death and preventing morbidity from treatment and TP53 carriers is an argument for doing it to newborns as well.
Thank you for sharing all that information, Dr. Diller. That was definitely very enlightening. I can imagine there's a lot of considerations that need to be taken into account when thinking about how this might be implemented and kind of the effects it might have on not just the individual, but on the family as well. And so I guess finally, what message would you like to share with our listeners about the importance of newborn screening for cancer predisposition and the work that's being done at Dana-Farber Boston Children's?
I think it's important for the listeners to know that gene first newborn testing, newborn screening is coming. I can't imagine that any of the current biochemical tests that we do, as well as additional tests for other diseases, won't be all incorporated into large panel diagnostics or screening warrants. So if it's coming, thinking about how cancer risk genes should be included in that is really important. The research that I'm doing with my colleague, Richard Barad, who's a newborn screener at the Grinnell Hospital, is focused on trying to establish the methodology, understanding of the psychological impact and ethics, understanding the actual clinical genetics in terms of the interpretation in normal people versus at-risk individuals, and then trying to establish the clinical care pathways for known carriers. Those are all those are all paths that need to be ironed out in order for this to work. I think that, my listeners, if you will, if they take care of new parents or are thinking about newborns, taking a good family history is really important. Having an open mind to creatively interpreting that family history is important. Using genetic counselors to help them with that, I think, is really important in this day and age. So we get to the point that we're doing this kind of genetic work, and then once we do that, we'll need the genetic counselors even more. But I think this work is a work in progress. We'll need a couple more years. I don't think much longer, 3 to 5 more years of research work to figure this out and do some pilots and see kind of how this rolls out on a population basis. I think that's the upshot of this conversation. It's not tomorrow, but it's not way in the future. And I go back to sort of the importance of family history and with not good physical exams to look for markers of cancer predisposition like Friedman syndrome or hypertrophy, that we don't want to lose out just because we have genetics on those classic ways of identifying kids who are at risk for cancer. So I think that's very important as well.
Great. Well, thank you so much for joining us today, Dr. Diller. It's been a pleasure. We've certainly learned a lot, and I hope our listeners feel the same way. So thanks again.
Thank you. It's been incredibly fun. Good luck with your careers as genetic counselors. You're doing a great job. And I hope you end up in cancer risk.
Thank you.
Thank
Take
you.
care.
Okay.
Thanks for watching DNA Today. To access all of our episodes, head over to dnatoday.com. We also have a lot of bonus content on there that you can enjoy. If you have any questions, comments, suggestions, guest pitches, you name it, send them in to info@dnatoday.com. We'd also really appreciate if you could take a moment to rate and review the podcast on Apple, Spotify, wherever you listen to the show. It really helps more nerds like yourself find the show. Also, if you like giveaways and other ways to connect with us, I recommend following us on social. We're at DNA Today Podcast. We also have a Patreon if you want to be the most level involved in the show. That's also at DNA Today Podcast. Thank you so much for listening and watching. Join us next time to learn and discover new advances in the world of genetics.
We're all made of DNA. We're all made of the same chemical DNA.